Well, it's a pleasure for me to be able to share some of my thoughts and experiences regarding assessment and how it relates to advancing healthcare quality. Quality is a mainstream topic. You can't listen to an agenda from a hospital or a clinical institute or even the government and not hear at least something regarding healthcare quality these days. Definitely a mainstream issue. When you take all of the information, which is pretty overwhelming, and sort of decipher what people are talking about with respect to quality, most of the focus is on the needs of patients, families, and the community of people who receive care in our healthcare system. Another goal, which I really deciphered down in the details from one of the government institutions, is to move the system of healthcare to work better for healthcare providers and reducing our administrative burdens and helping us collaborate to improve care. Now, this is actually difficult to do. I've been waiting, as I'm reading this, I said, that sounds really good. I'm waiting for that to really be an issue as I sign 20 and 30 charts and adding more and more documentation. One of the programs, at least, that gives some detail and structure specifically regarding the second item, which I will focus on regarding healthcare providers, is the National Strategy for Quality Improvement in Healthcare. And when you get down to the details, there's 4 sections. One is sort of an introduction with background, and the second part is aims, priorities, and goals. Third part, policies and infrastructures, and then next steps, and sort of looking towards the future. Within the introduction, obviously, again, it's more background and some details there, sort of building up why quality needs to be a national strategy. The same as the aims, when you look at some of the details, is things that we're all familiar with in terms of making care safer and promoting wide use of best practices and so on and so forth. This is the one that sort of relates to our goal here today. And it's sort of deep in the middle section here of this list. But as you look closely, health information technology, I consider simulation to fit in that group, although primarily they're talking about the electronic medical record, but in the language it includes other modalities that collect any data regarding healthcare information. Evaluation and feedback, and now I'm getting really excited about this. Training, professional certification, workforce, and capacity development. This is right up our alley. This is what we're here for. And so I take those 3 and sort of really focus on that, because this is the area within quality that I will focus my discussion on today. And again, the checking point and the reality is that there's barriers, but there's also opportunities. And as I thought about this, I thought about my own motivation and my own experience. And as a medical student, it was very interesting to me to think of the use of touch as a diagnostic modality and where does it have its place in medicine. And I am very thoughtful about the numerous times that I personally observed a senior clinician performing a physical exam or a senior surgeon performing an operation, and standing there watching what they were doing and realizing that I really can't transfer what they're doing to some sort of tangible knowledge just by watching them. And so I would get to the point often where I would just wish that somehow the 2-point discrimination and the knowledge they had at their fingertips could somehow just magically be transferred to mine, and then I could do that magical examination of the knee or a breast exam and find all of those little lumps and tumors that, the well-trained surgical oncologists were able to find. And one story that's sort of worth telling in a little more detail was the night that I stayed up reading about a procedure that I was going to participate in as a second-year resident. And this was a procedure on the prostate gland. And this is a normal prostate here, and then this is a picture of a one that's enlarged. And the procedure that I was going to observe was called the suprapubic prostatectomy. And I looked at every picture book, every video that I could get my hands on. There was no simulator for this one. There still isn't yet. But I was very excited that, I'm going to go and see this really cool procedure, which looks like it's, got some really interesting anatomy. And I go to the operating room, and this is what I see for an hour. Horribly disappointed. And so, but when you step back, I'm not the only person who's experienced this. This is every day in medicine. So how, looking at the back of a surgeon's hand, am I really going to have any understanding of the three-dimensional anatomy of the prostate, an enlarged prostate with respect to the bladder? And it's a tough situation. And when you step back and look at it on a larger scale, the clinician who is responsible in an academic medical center has competing goals. One goal is to provide the most hands-on and hands-on experience to the learner, but at the same time protecting the quality of care that's provided to a patient. So some of the things you get to do, some you don't get to do because it's too dangerous. And so at the end of the day, what is it that you really know? Then I sort of went further, and this was coming from this. Elliot Eisner is one of my professors when I was at Stanford, and his work, which is nationally recognized, he's a pretty famous educator, and one of the books that he wrote, his baseline theory relates to art, and for him, whatever your experience with art sort of helps to determine what type of learner you are, how you experience information. And he's become so famous that other people have written about his work. Working the Ideas of Elliot Eisner is this book that came out in 2004. And I read one of his books, and this is the quote that sort of stood out to me. The ability to secure meaning in the course of our experience is a basic human need, but meaning is not simply found, it is constructed. And the age-old theory relating to this is called constructivist knowledge, the constructivist theory of knowledge, and that you layer on levels of information. And so as I start to think about my experiences on the wards and in medical school where I get to do part of a procedure one time and another part another time, it came to, and combining that with Elliot Eisner's work and the constructivist theory, I came to this question: how do you really know? If this circle or this donut represents the truth, a full body of knowledge, a content knowledge, how do you know how you've put it together? Which one are you? Which one of the four are you? The only way to know is via assessment. And even still, it's not perfect because our assessments don't always help us get to the truth in terms of an answer, but it's sort of an interesting concept to think of. But at the end of the day, in terms of a constructivist knowledge, in terms of even deliberate practice, what we talk about, it's all based on assessment. You can't do deliberate practice without doing assessment first, because deliberate practice means that you are deliberately focusing on things that are specific to your needs, not the whole classroom. So when we give courses for students and residents and clinicians, and it's a topic that's of interest, it's a deliberate delivery of knowledge, but it's not deliberate practice for an individual. It has to be based on assessment. So going back to the focus on healthcare professionals and getting into really assessment is at the key of being able to provide a sound evaluation and feedback, which is the breakfast of champions. You've got to have feedback. It's got to be timely. And I will go into just a little bit of describing, the difference between formative and summative assessments. Formative assessment in summary, is sort of those body of activities that are undertaken by teachers and students, and it provides information in a form of feedback that will help you modify the teaching and learning activities that you're doing. And so it's a continuous interaction. It's not distinguished by the actual format, but how it's used. And it's really used to change your course and make things more specific towards the learning goals. Formative assessments, this has been researched and done as a meta-analysis, and the conclusion by Black and Williams was that formative assessments produce more powerful effect on student learning than summative. And so now I have to explain summative, but I've got a few more details about formative before I do that. Again, is to provide feedback to teachers and students to modify subsequent learning activities so they get more and more specific. Identify and remediate group or individual deficiencies, and move away, which is really the focus of a summative assessment, which is grades or end goals, moving away from that to focus on the learning process and specifying that more and more so that you get to that truth in terms of your knowledge. It even makes you more aware of what type of learner you are, how you process information, how you need to get feedback in order to move to that next level. So frequent ongoing assessment allows for both fine-tuning of instruction and focusing on the student's progress as opposed to just the end goal. And again, summative, this is one of the more sort of known scenarios that separate or give a good explanation of the difference between summative and formative assessment, is that summative is an assessment of learning, whereas formative is the use of assessment for learning. So it's two different things. Again, summative assessments can be high stakes, which is usually not a characteristic of formative. And in that instance, it's a well-defined assessment. There's a clear pass-fail scenario, and it has direct consequences in terms of you having privileges to engage in an activity or credentialing in that scenario. And again, getting back to feedback, this typically involves a focus, detailed content in terms of what was learned rather than simply a test score or a measurement. And that's what it should really be focused on in terms of getting those details. And again, that's really the central function of a formative assessment. So now I want to shift gears and kind of tie it all together in a different focus. So when we look at what we do in clinical medicine, a huge barrier is really the silos that have been built, and we all know this, as well as the culture. So you look at this team of clinicians here, and as I saw this picture, I'm like, this looks like this exact, handoff scenario in the emergency room. You've got a group of specialists who've come down to see a patient, and then they're now handing off or signing out their recommendations for this patient. The person they're talking to trains differently, trains separately from them, may have a different language, a different decision-making path, and so half of it's in English when you're when you're signing off a patient. The other half is sort of questionable at best because you don't really understand it, and you just say, well, that's their specialty, they're the experts, and I'll depend on them to know that part of it. And we sort of have this trust relationship because we've already built those silos. The other thing in terms of the culture, we haven't quite fit together in terms of having a team approach as much as we need to with respect to providing care to our patients. Many times, one patient who's got a number of things going on with respect to the diet, the medications they're taking, a surgery they may be planning, you see one doctor at a time, and at best maybe you get a letter or a note such that there's some continuity or understanding of the plan. Even better yet, maybe a teleconference. But we still have a lot of work to do in this area in terms of pulling it all together and working as a team. And so this is definitely another barrier, if you will, in terms of quality in healthcare. The other thing is rapid advances in technology and knowledge. almost every month there's a new capability with respect to CT scans or a new laboratory value or a new antibiotic. And so when you look at the amount of knowledge that continuously grows, if you're on the constructivist end, you're constantly building, trying to get to that truth. And so it's sort of a never-ending journey, if you will. Another specific example I'll give in terms of one of the barriers we sort of face in this endeavor is even curriculum development, and I say that because this is what we do, and so I want to push some buttons here. We could do better, and I'll give an example of a problem. So one of a project that I did with a colleague of mine, we did a survey-based study, and it was titled, Faculty and Resident Perception of Resident Learning Needs in the Operating Room. And so the main question is, what operative management topics do residents and faculty perceive as knowledge deficiencies when a resident presents to the operating room? So the faculty's opinion and the resident's opinion about the resident. And we had several topics, some of them in the preoperative phase, some relating to postoperative, and some relating to intraoperative. And it was a checklist, and everyone filled out the form individually. This was at a national meeting, so this was not limited to a specific region, if you will, or a specific program. There were 93 residents who responded. It was senior level residents that have the privilege of going to this annual meeting. And this is how they rated them in order in terms of the number of people that selected each item. So at the top of the list 60% of the residents chose instrument use and selection of suture material as what they feel deficient in when they show up to the operating room. And when you compare that with the faculty, you all see it. There's the punchline you don't have to say anything. What's at the top of the list for the residents is at the bottom of the list for faculty. What's at the top of the list for the faculty is at the bottom of the list for residents. And so we are all well-meaning when us experts get together and develop a curricula for the residents. But the problem is that we're so far away from the things that they are learning in that process of constructing that knowledge and getting to truth, that on one hand, even though what's at the top of our list may be true, that these are their deficiencies, the reality is that they have other concerns themselves. And we're talking adult learners here. So in the end, you kind of look at this, and all of it was just significant across the board. Who's right? So it gets into perceived needs, which is that on the side of the resident. They have perceived needs, but they also have unperceived needs. And the residents know their perceived needs. They want to know about suture selection and instrument use. The faculty know what they feel are their perceived needs. But on the other hand, what you start to see is that the residents are overconfident on the unperceived needs. Residents, when we get into the details, faculty want the residents to know 3D operative pathologic anatomy. Then the residents are confident that they know netter anatomy, which is not going to help you get through a difficult operation. So they may be a little overconfident in those things that were on the bottom, or just not really knowledgeable that these are areas that they need to focus on. But I can guarantee you, if you develop a curricula that solely focuses on what you think these adult learners need to know and you don't address their issues, you're going to have some distractions. They're not going to be there with you 100% because they're in the back of their mind thinking, okay, when do we get to focus on the things that I want to learn as well? So the take-home message is you got to have both people at the table. The learners that you are building a curricula for, and you can take this out of the surgery realm, just in general, if you are developing a curriculum for a group of learners, you got to have them at the table, because they know what they don't know. And you've got to have some sort of compromise such that things come together, and needs assessments are really critical. And again, that will help you build the most powerful simulation-based assessments, is when you really get that grounding from both groups and develop something that's in common. The last thing I'll say is, innovative assessments. I think that we tend to, and I like to talk about the curriculum, we tend to focus on curriculum and content knowledge and delivering facts much more than we do the actual assessment. And we've really got to tip the scale somewhat to really get towards what adult learners need. Everyone has their own way of getting towards that content information, the internet, the courses, the sim lab, the lectures, whatever have you. But the truth is during the assessment, and then enabling someone to realize where they are on that curve of getting towards the true knowledge. So now let's flip and be positive. Let's talk about the fun things. What are the opportunities? And I think what's been fun watching over the years is some of the advancements in team science. I won't get into those details. I'm more than halfway through with this presentation, but I will show some scenarios which we've all sort of had some experience with looking at. But it's fun to think about where we were and talking about our videos that we've captured of teams 5-10 years ago and where we are now in terms of the checklist, the language, our understanding of how to look at a team, how to do debriefing. We've come a long way, and it's pretty exciting, you know, to look at some of those same videos that we've looked at before. And I'll show one or two of them from our new center. So again, I think that both George Keeler and Ron Slowinski, as well as Donna, told us about the wide variety of people that come to our Sim Center. So I guess I lost the volume. But this is a view of a paramedic team, and what you don't hear is the person here who has the bag saying in a very calm way, yeah, the sats are dropping kind of fast, aren't they? So you can tell that the person's maybe been through some debriefing training and, you know, maybe probably hadn't done well before and was trying to be pretty calm. It's like, okay, you need to speed that up a little bit, buddy, but didn't say it that way. And it was, you know, and so to look at this, and we're kind of proud of ourselves that it didn't, you know, it went over the way that we thought. And so it was very helpful. I don't know how to recover the sound here, but I'll keep going. I think I can just kind of ad-lib after watching the videos. So this is a team here, similar scenario.
So we'll get 2 minutes of CPR in the first here. John, you got the airway. Yep. Do we have a pulse ox?
Someone raise the bed.
Yeah, it's hanging up right here. It's okay. Set that on there.
Similar scenario here, obviously a little more intense, where you've got a larger team, a lot of noise, and a lot of people doing things, but the same thing. The blood pressure's dropping precipitously, and everyone's still kind of calm and nice, and no arguments, you know, no fights breaking out, no things flying across the room. So we're pretty proud of this. Let me see if I can get to the next one. No. I don't know how to, oh, is this?
So you just want to make sure you get enough clearance then. Oh, you got plenty of clearance there. All right, that wasn't too much work for me. How about you? You probably had the load there with the legs. So. A little bit easier than doing a slide board transfer.
So the first thing I noticed when I first watched that, I thought, that's a lot of complex equipment. But then you look at the team of nurses and they're like, yeah, this is much better than the slide board. And they're really excited about it. And I'm watching and I'm thinking, oh no, he's gonna hit his head on the top of the bed. And I'm nervous about it. I'm like, oh my God, that's like they're doing it, you know, operating heavy machinery. That's gotta be stressful. And then that just shows the difference. I'm in my silo. I never use that equipment. I probably never will. But for them, they're using the slide board, and it's probably labor intensive for them. And they're perfectly happy using this, what looks to me like dangerous heavy equipment. And I think, you know, that just shows one of the benefits in, like I said, in terms of capturing simulation and really trying to break down those silos is coming in and watching groups outside of your specialty do their thing, because they have a completely different experience than you would expect, and so that gets to be pretty exciting. And then I'll give a few examples regarding some opportunities with simulation technology. Some of them we're very familiar with. This is one of a project that I had done many, many years ago with putting sensors in the airway on a mannequin for intubation. And when you look at this graph here, this is a graph of the amount of pressure applied over time. The different colors represent a different area of the anatomy within the airway, and we've got sensors all over the place. But you look at this sort of burgundy sensor here is really a sensor on the tongue, which is kind of counterintuitive because we don't think about the tongue. What's purpose, does it serve within intubation except just to move it out of the way so you can see? But it's actually where the laryngoscope sits. And so I can actually collect data on manipulation of the scope with a sensor on the tongue. There's also sensors in the on the vocal cords. And so you look at this 12-second intubation, looked like it went pretty well. And the first blue bar is when the tip of the ET tube passes the vocal cords, and then the larger blue is when the balloon passes. Even though it's deflated, it still has a little more surface area than the tip. Then you look at the graph of a novice. A lot going on there, right? So the first thing I have to disclose is that the scale is a little different because I had to squeeze the graph to fit it on the screen. This took 3 times as long. And when you look at the first part of the graph, that burgundy line again, there were several manipulations of the laryngoscope, held the laryngoscope in one place for a while, but wasn't able to pass the scope, probably didn't get a good view. And then you also start to see sensors in this graph that you don't see in the other graph for the experienced intubation. And that's actually because there's extreme tilting of the neck and some other things going on. So it's not necessarily that the more sensors you see, the better. Actually, in this case, we've got sensors in places that you shouldn't see. But you can just see how this kind of goes, and there were several manipulations again of the scope, and finally they got it in. And so if you think about a summative assessment that would mainly focus on getting the breathing tube in, this person did okay. But you look at how long it took, and was the person well oxygenated? Now what's the blood pressure? Now what's, how much atelectasis do you have because you didn't get it in time? And so then things get to be a little more detailed, and I can give a lot more feedback to this person in terms of the process that they went through in terms of getting this intubation, as opposed to just, great, I'm in. So again, under the opportunities, I think that besides some of these new, technologies and our advancement in the science, I would just say that we really need to push for a wider adoption of the concept of quality. I think that we're headed in that direction. We've all heard about, lifelong learning, but I think we also need to pull in that assessment piece. Again, we've talked about maintenance of certification, and now we're starting to talk about maintenance of licensure, but how about maintenance of quality? 2 different scales, 2 different goals. And I think that if that was something that was ingrained in us in our culture, we would do things a little differently on a daily basis, and I look forward to the day that happens. Right now, what we're struggling with is, if we did have a maintenance of quality culture, there would be intrinsic motivators, which tend to just work much better for really getting that, activity to happen without as much pain as it is when you've got an extrinsic motivator. Pay for performance, I didn't say that. Other things that are, it tends to be more on the punitive side, and so you do it because you have to, but it's not the same. It's not ingrained in something that's positive that you want to do, and you complain about it. So I think those are 2 different ends of the spectrum, and some things that we need to sort of deal with when we're talking about how do we get towards, a quality state of mind. And I think that, just as I said, some of these examples and new opportunities are pretty exciting. And again, this is the end goal. We need to know where we are. Just yesterday, I had a surgeon call me and say, or I had a meeting, and he wanted to come and visit the Sim Center and look at it and see what's going on there. And I fully expected that. He says, I want to teach my students how to sew or do something like that. He said, I want to come down here and do some procedures that I'm not that great at. I said, okay, great, let's do that. I mean, what do you say? This is where we need to be. It needs to be expected that those who are, had stopped doing a procedure for whatever reason wants to get back into doing that, and we have a venue from a CME perspective to address not only the students, the residents, but also the practicing clinician. So thank you very much.